So when we comes to Digital India today, in this context of this panel, we're going to mostly discuss Digital India as a context of the campaign launched by Government of India, the programs of Government of India. And though Digital India could mean a lot of things to a lot of people, but our context is mostly all the policies, programs that the Government of India is providing as part of Digital India. How are they helping us? And how are we going to take advantage of it to deliver care? I'd like to start with you, Ravi. And the reason for this is continuity from last year.
Okay.
You know, last year we spent a good 1 hour going through decentralization of healthcare, talking about how digital is going to do that.
Yeah.
So in last 1 year, how much do you think the needle has moved?
I think we have done significant movement in this direction. If you recall last time, we did talk about getting into the EICU space as we discussed earlier. And today I think we are proud to say that we have over 1,500 beds that are running ICCC plus ICCA, which is basically the platform which brings in data connectivity to on a critical care level to various hospitals. And typically what we started off was saying that this ought to be in the hub and spoke, in the sense that you have the care which is there in the tertiary clinics, tertiary hospitals, and the spokes are the ones which are on a receiving end where the technology actually flows through. We have been able to see that happen. Most of the implementations have actually taken place between the Tier 2, Tier 3, Tier 4 cities with respect to being overseen by the hub. So in that sense, yes, we have seen considerable progress. And not only that, if I were to sort of take the case beyond India, we have seen implementation in other countries as well, wherein we have been able to use IT as a force multiplier in terms of decentralizing care. Indonesia is a case in point. We have tied up recently. There was an announcement there saying that we have tied up with Telecom PT for deployment of MOM. We started off with 2 centers. We are now looking at 50 centers there. So in that sense, yes, we have made some positive steps. We are looking at chest pain centers, which Prasad talked about earlier in the day. We did 5 centers with Manipal in the Udupi district. We are now looking at taking in offshores into Myanmar, where we are looking at 8 centers there. So in the sense, yes, we have seen considerable progress, and we possibly believe in the conviction that digital health is the only way that we can sort of take this forward and ensure affordability, accessibility to the masses in large.
Thanks, Ravi. So on that context, he's talking a lot about EICU, remote, but you are on the ground. You've probably have the largest telemedicine implementation in Asia. How do you think Digital India is helping you, especially in context of overcoming the challenges we had with telemedicine for a while now?
So I guess telemedicine, if you as a concept, looks extremely sexy and exciting. Challenges that are there is that when you start implementing it, there are small nooks that keep pestering you. So for example, last mile connectivity, that still requires work to be done in spite of what we believe has happened in India over the last few years. Last mile connectivity still remains a challenge. Technology acceptance is still a little, lagging behind. Especially I can talk for the medical community. We are very resistant to change as far as technology is concerned. We try and beat back technology as much as possible, try and say that this does not work for us, but the writing is on the wall. We have to accept it at some point in time, whether we like it or not, we will have to be there. So on the ground, there are these 2 basic challenges. One is connectivity. Second is acceptability, and the third, of course, is in the context of India or the developing market, is the cost. And the cost, if I go to a tier 2 or a tier 3 town and go to the hospital there and I talk about a product, everybody is overwhelmed. Everybody is, this is it, I want this. As soon as I start talking about the cost, everybody seems to shy away from the whole thing and say, okay, I think we can talk later, maybe we're not yet developed, So those challenges are still there. Now, how can we make this more cost effective? Can we have models which are, different? Obviously we can't get the American standards here. As soon as you start doing that, you end up with the cost barrier. So how can we tweak it to the Indian scenario is what we are working on. So we have come up with, slightly different models which make it more cost effective for the implementation in developing countries like India.
Yeah, just hold that thought, Doc, because I'll be coming back to you. So you said connectivity, acceptability, and cost.
Yeah.
And cost is an issue. So, Pramod, I'm a big fan of Aadhaar now. Okay. That was 5 years ago, I didn't know what it was doing. Today, I'm very proud to have that card. So, Rajesh Patra talked about linking Aadhaar for taking appointments. How does Aadhaar play into this whole scenario, the way you look at it, digital health?
When we started in 2009, we realized lack of identity. The first, everything you do, you have to establish who you are. And we talked about EHR, healthcare records, we talked about security. But if you don't know who the person is, how are you going to secure that person's EHR records, for example? So it is not only actually in health, it's everywhere. And you walk into an airport, you walk into a bank, you walk to ask for your pension, scholarships. The first question you ask is, who are you? What's your identity? And half our country doesn't have it. So I think the purpose of Aadhaar was to create a unique online, actually digital identity. And it was challenging to get people to understand. Even today, yesterday somebody was telling me that that guy, the bank didn't accept his printed e-Aadhaar. That we allow you to print any number of copies because there is nothing called original in Aadhaar, by the way. You are your original, right? But people don't understand. People still in the paper world. But the way Aadhaar evolved is that you give your biometrics. Most of you may have Aadhaar. We have covered 1.07 billion. So, it's more than 1.07 billion people have Aadhaar. They give their biometrics, and actually we do a biometric deduplication. That means every one of your biometric is actually compared against the database to make sure you're unique. So every one of 1.07 billion people are unique human beings. And it is verifiable online now with a digital identity. I think Geo and all is taking advantage of it. Banks are taking advantage of it. It's completely paperless. But it doesn't stop at Aadhaar. I think that's what we realized as part of Digital India. There's a set of frameworks that evolved on top of Aadhaar called India Stack, a collective term used as India Stack. It involves identity, which is provided by Aadhaar. It involves digital signature provided under the CCA and the Ministry of IT called e-sign. So you can actually have 1.07 billion people sign contracts, paper, forms with actually no paper. So that's why Geo is able to do a completely paperless SIM card opening, because they don't have to get a paper sign, they can actually digitally sign. Every one of these can digitally sign. It's live. We have about 2 million e-sign authentic transactions going on today. Aadhaar, we do about 15 million authentications a day. We have 500 million authentications a month, 400 million authentications a month. So it's very heavily used, and you'll be surprised, it's very heavily used. On top of that, we just got notified by the Ministry of IT on what's called digital locker. Super important for EHR. Actually, we have proposed to the Ministry of Health and Ministry of IT a model through which you can create federated EHR without having a central EHR systems. Completely leave the data where it needs to be, where it already is, in the hospital system, lab system. But how can this digital locker framework unleash that data, provided a strong identity and authentication is attached to it? I should not be able to pull up your records, for example. And I should be able to pull up my records. Today, even I can't pull my records, right? It's actually locked. So Digital Locker Authority is actually, there's an authority called Digital Locker Authority of India. It's actually notified. So you please watch Ministry of IT. Tremendous work is being done in terms of opening up data that is today locked in. By connecting through digital, that means you can do paperless appointment, paperless sharing, paperless, you can exchange your records, all with your control. I think that's called electronic consent framework. So these layers are actually live, and they're all there, and 1 billion people can take advantage of it. And the best last one was the unified payment. You must have seen that also coming up. With the demonetization, I think it's a lot more talk about digital payment. So today, everyone with a bank account can pay and receive money, and 1 billion people can be authenticated. They can sign contract with no paper. It's a shame if healthcare doesn't take advantage of it.
Out of curiosity, does anybody here not have a Aadhaar card?
Yeah, very few. I think we have covered 1.07, so we still have probably about 200 million people.
200 million, you can see three
Yeah,
here.
the long tail. That long tail still exists.
But point taken from Ravi, you've been there. You've been a pioneer in the startup space. You are a leader at the NASCOM. At the product level, you advised startups. How do you see this evolving from them, from the context Doc was talking about? He talked about connectivity, cost, and acceptability. What is your perspective? How is it working for you? And what are the common challenges the startups come up to you with?
So, the way I look at healthcare across India is there's the big chasm in my mind. Okay? I mean, the hospitals that everybody visits in this room are equipped to the latest and greatest, practically. I mean, you could be anywhere in the world for all that matters. But that's not India. There's about another billion at least. And I'm being very generous in my definition of who can access the kind of hospital you're talking about, that I'll guarantee you any one of us walks into those hospitals, we'll run away, even in a sick state. You would not want, there's no equipment there, there's no connectivity, there's, the standard, you're dependent on the doctor's good skills and diagnosis, right? That huge chasm needs to be bridged. It won't be bridged with the technology that is in the top hospitals today, because that technology is not suitable, as you pointed out. The technology you need to develop has to be built by startups, in my mind. By startups, I mean broadly. It might be innovation from Philips, it might be a big company that innovates for India. It might be a small startup that innovates for India, It might even be international players that come here and build for India. I think that's the big chasm, and that's a huge opportunity. Because the technology that has to be built has to be resilient. All kinds of conditions. You go into the hinterland, into rural India, it'll be dust, the power will be fluctuating like mad. You might get connectivity a little bit, but even that might be a long time coming. The kind of skills that you need to set up that equipment has to be very minimal. It has to be literally out of the box, it has to work. It should not have any fancy buttons that will break. Then you need supply chain to fix that. And where will the supply chain come to fix it, right? It has to be reasonably self-contained and maintainable on literally, not solar power, but on some kind of a variable power that goes there, right? Finally, it has to be massively scalable. It has to be affordable, right? These are the basic attributes of whatever innovation you're going to do that's going to deliver proper healthcare at scale to the other billion. And I don't see us having delivered that yet, and even coming close. I think last mile connectivity is going to be good for two reasons. One is, many of these devices, what you're going to do is, if you think about the cloud, on the edge you'll have sensors, at the core you'll have the intelligence. And this is the way you'll actually build new devices, which is, you can't bring that whole CAT scan machine there. You can't, because you need an air conditioned environment, you need dust proof, you need all this. But maybe you can bring a very innovative sensor that then connects, and then the actual CAT scan machine is somewhere else. I think, we oversimplify by saying it's telemedicine. That's going to happen. Because, you can literally do it on a smartphone to some extent, right? But it's these sensors at the edge, a light edge, very thin edge, a deep core that is scalable and distributable, right? That's going to be one kind of motion, I think, right? The second, is going to be the education that you can deliver. 90% of healthcare, as Hamid pointed out, is just making sure the person understands what the issue is, discover who can help with this issue, getting to that person, right? And getting there in a timely manner. That's a second kind of area, right? The third is, I think, data aggregation. You don't know what issues are, if you have a pandemic somewhere, and millions of people get wiped out or something, you will need data aggregation to be able to manage that in a way that's scalable. India, 24 million births a year, okay? And 4% live mortality rate for those children. Now, That itself is a stat to just ponder. That's a whole country being born every year, right? And even the mortality rate is a country, or in some sense. And so there again you can improve with education. Better health is the second thing, I think, and then this data aggregation. How do you do it at scale? Because if you just solve the problem in one state or one corner of India, it's not going to have much impact. It's just like the kind of care we might go to. We need it at scale, and that's where the connectivity will come in my mind.
Very good point, Ravi. I think what you added to Doc's framework, I'm using his framework because it's cheaper, easier to remember. He said connectivity, he said cost, he said acceptability, and he said productivity, right? And you are adding scale to it because obviously India is a large country. And that brings me to you, DJ. I know you are flying below the radar right now as an EMR provider, and I see your model as something which very much aligns to Ravi's vision, right? Like he talked about scale, he talked about cost. He said you can't drag the CT scan all over the country. I think though you're not in the CT scan business, you're definitely in the EMR business. It is something that you align to, or you completely disagree with Ravi and you say, hey, we want to build Big Bang.
Sure. So the points that Ravi made are very valid, and I think you're right in your assessment that what we are trying to do, we've been trying to do for the last couple of years is how do we bring innovation, how do we bring more efficiency, how do we bring data aggregation, information analysis, etc., in practical terms to healthcare providers and to hospitals in general. Our understanding is there are two kinds of markets that all the speakers have alluded to. There is this urban market where we have maybe top 10 hospitals. We can all count them at our fingertips. We all know them. These hospitals have bleeding edge technologies. Anything that's new, probably being used in the Western world, in the US, etc., will show up or has already shown up in these hospitals and is being tried out as pilots, etc. These 10 hospitals, the remainder or the vast majority of the hospital systems that we get inquiries from or who talk to us, these are guys who approach us. The first thing they say is, hey, you know what, I'm not a Manipal, I'm not a Apollo, but I want a technology that is closer to me. So I want something that works for me. So the needs of that market are entirely different from the needs of this urban hospital. We are very myopic in our vision sometimes because we live in cities and go to city hospitals, but the rural hospital or the small town hospital faces a very different set of challenge. Startups, it's our duty to keep innovating. That's my only suggestion to every startup here. I know that physicians will resist, hospitals will resist, and they have every right and duty to do so because end of the day, they're taking care of the patient. But as startups, it's our prime responsibility to innovate, to throw something at the wall and see if it sticks, because it's only through that we'll come up with a technology that actually makes a difference. Let's talk about data aggregation. Data analysis. There's, of course, we are going to talk about this in the next panel on machine learning, artificial intelligence, etc. But then, how can we scale this from a very small primary care facility in a village or a small town, and how can we scale that all the way to the district, the national level? That's where I think startups can innovate, bring in more.
Doc, when Ravi and DJ, they talk about scale, they're talking about distributed. How do you see security playing a role? Because Rajesh Batra here is very worried about security. He's not worried about too many other things today, including Bangalore traffic.
Okay, let me just echo what Mr. Batra said. I think security will, in future, become a huge concern. First of all, it is very important to understand who that data belongs to. Today, the person operating the system owns the data. Now, how that data is used by that person is not defined. It is not yet written. What part of that data can be monetized by the provider? What part of that data cannot be monetized? What part of that data is completely out of purview, only private to the individual? All that will have to come into place.
Pramod, you've dealt with this. Obviously, I'm sure in the architecture it's there somewhere. How does that play? Security is a big concern, whether it's Ravi or Rajesh or anybody here.
Frankly, I think while the security is at most important, I'm not too worried. Maybe I've come from the software background. A lot of these IoT hacks and all happening is because hardware guys don't know software. I'm just being blunt. The guys who build Wi-Fi APs, for example, or the sensors are clueless about how it should be secured. Because they just make, traditionally, the guys who make cars have no freaking clue how to secure stuff. The blend is not yet fully studied, right? Software is taking over the network layer. Software is taking over the motherboard of the car. So I don't think it is fully studied. So there is going to be a time where you will see these issues popping up very rapidly. But I don't think it's an unsolvable issue. It is solvable today. Very strong security technologies exist to control end-to-end encryption, end-to-end signature, trust establishment, everything else. In the database, actually digitally signed and encrypted. So for example, if the database rows, even ourselves we can't see. Our own database administrator can't see. Our own people can't see. Very well architected, it can be done. It's just that the hardware guys are getting used to, traditionally they are very independent machineries, disconnected machines. The engines are not connected, the motors are not connected. Today everything is starting to get connected, so it's the first generation that is getting connected. Especially hardware, so the G's, the Philips also, who are building it have to have software security architects embedded in their team to ensure that the best practices of the software layers are actually coming in the IoT world. Otherwise, you will see all these issues.
I think the security thing is overstated in some sense, right? I think, healthcare especially, you need more transparency, you need more data to be available to make more efficacious outcomes. If I know somebody's individual health, I might be able to impact them in a job interview, I might be able to do a couple of things, but it's not the end of the world.
Correct.
It's not as devastating as knowing their password to their bank account and other things that are much worse, right? I think, we need much more transparency. You need to know all the data outcomes for a hospital, like for a procedure, for a doctor. With the concerns of security, we then, kind of obfuscate all the data, not allow that transparent discovery to happen. It will actually hurt outcomes. I pride and value my privacy. I think in aggregate, I'd be glad to have a more open system than a very, very closed system.
Actually, now you gave me two brilliant ideas. So let's do this. Let's break protocol. So Ravi, I'm going to put you on the spot. I know we go back a long way, but my friend Pramod Verma here says that hardware guys don't have software protocol ideas on security. You are probably one of the leaders in medical equipment in India and abroad. So how are you countering that? Do you agree with him?
In fact, I think we have been fortunate to have both hardware and software guys with us who possibly look into it and try and do this analysis from all aspects. I would be proud to say that we are setting up we do have a center of excellence here from a security perspective, and that's got to start with about 20, 30 engineers dedicatedly looking at what are the possible options by which you can break into it and what are the preventions that you need to do. In fact, Shiva and his team are working with the Department of Defense in trying to see how to build security and take it on to the next level. So there is a constant endeavor to try and sort of be ahead of the pack in terms of security and privacy. But at the same time, I would possibly agree with what Ravi said in the sense that it's overhyped. I think the wants and the catering to the basic needs are far more important than security at this point of view for where we are today. Yes, we are enduring to sort of take security to the next level and ensure that data is not compromised. At the same time, if you look at the financial institutions, they have been running for years. And this is something that has been sort of, it's a proven technology. It's nothing that is new to us in that sense. It's just a question of applying those technologies into healthcare and then taking it on to the next level.
Here we are saying that access is more important than security. So I'm going to throw the question to each one of you. That means the urban centers have access, rural has no access. On the other side, you have the risk that somebody might know that you suffer from a particular disease, and let's not assume there's no social stigma to it. People don't even disclose tuberculosis because there's a social stigma to having TB. So the question to you, starting from you, Doc. Ravi's already said he thinks access is more important than security right now. What is your perspective?
Data, if it is used, if it has to be used for epidemiological purposes, if it has to be used for, charting out what the trends of a hospital are, what the trends of a doctor are, please, you should use it. There's no doubt on that. Who's the custodian of that key is the question. I'm okay with data being accessed for a larger purpose. Yes, because then privacies are obviously not compromised because you're cutting out all the private data out of that, filtering out only the medical data in more in terms of epidemiologies. That's fine. But the custodian has to be the right guy. Can he be the only person left with that key is the question.
We all know where we live.
So yes, I'm not saying security is zero. Okay? All I'm saying is don't over-rotate on it. You know, you're going to architect something, let's aggregate the data, let's have a policy that says we'll put rules in place to protect exploitation of the data in an unwarranted way, to ensure that reasonable privacy is provided, that people are in control of their own data. Right? I think that will come naturally. I think, as we build the infrastructure out, I don't see a problem. But if you start overhyping the data, then people may not even give you the data. It's like the same problem that somebody said, they don't even go do a health check. They might say, now if I go do a health check, somebody's gathering the data. If you start hyping the security issue, that's all. All I'm saying is technology, there are lots of good technology solutions. Aadhaar will be kind of the identity, the digital locker will be the repository, I think the access control, the ACLs, the audit trails, everything will be in place. I don't see a problem there. That, first of all, you have to gather the data. We don't even have the data really, okay? Practically, for almost everybody in this room, I'm sure you don't have any record that you can pull up today on your phone that will tell you whether you were vaccinated for X or Y, or when you were vaccinated, what was your last thing, right? It's not there. Even for the people who are sophisticated, who have 3 phones in their pocket, right? Don't have that data. So let's first get the data. Let's make sure that we have the frameworks in place, right? And that's my only point. I think, and I think this whole IoT thing about, the IoT devices being exploited, very different. I mean, that is like, I can exploit all the DSL modems that are given by the telcos here. It's admin. We all know what the password is, right? You can just drive around in your car and exploit all of them. That's what this system did, okay? There's nothing different than that. I mean, so if you change your password, that exploit goes away.
No, that's
it's just a little bit of hygiene we need. And that doesn't then cause all the medical devices. They'll have a different system there. They have different protocols. They're not as straightforward now to break into as that, right? I mean, I think, again, we create hype and scare with something that is pretty straightforward, right?
So if I hear you, Ravi, you are clearly saying don't put the cart before the horse.
Yeah.
Let's not get
I think we got to focus on good healthcare. We got to focus on the benefits technology will bring to healthcare delivery. We got to focus on accessibility. We got to focus on affordability. We got to focus on delivering on those first. If you start worrying about data privacy and how many layers of privacy security you'll have, you'll increase the cost immediately. You'll be HIPAA compliant, but nobody will be getting healthcare.
Going back to his point on cost, which is the stumbling block. Yeah. So DJ, do you agree, disagree?
There are multiple aspects to this, since I've been listening to all the speakers. Of course, our solution is HIPAA certified because it caters to multiple markets, and I'm sure most of the good solutions out there are already HIPAA certified. That takes care of some sort of problem that may occur around security. And as the other speakers pointed out, the framework and the technology required to provide the right kind of security for any kind of data, be it financial or be it healthcare data, is already present. It's deployed. It's working fine. That brings me to one aspect, which is not digital. Data issues, if you look at predominantly what's happening with hacks and healthcare hacks, etc. in US too, most of the hacks or most of the problems don't start with technology, they start with people. And that's the biggest factor. I mean, even today, how easy it is for me to go into a hospital, maybe a small hospital, request for the patient's data, and a lot of, I don't want to name names, but pharma companies do that. There's a lot of ways to get that data out, and that's just a human process. So I'll put the best secure system, on the planet, but what if somebody just, hits a print button, gets a list of, everything that is needed, and just passes it on. So, as Ravi said, we should focus on security. There should be, a basic sanity that is needed, and good secure systems are needed. But it is not just that the technology can solve the problem, and a human can very easily bypass any secure system because he or she has access to. Which brings me to the point Doctor mentioned, which was about access of data, and I beg to disagree here, sir. If I understood or I heard you correctly, you said that as the person who creates the data, the creator has access to data, or he or she owns the data. From a patient perspective, not being a clinician, and even though I have clinicians in the family, being a patient, I think that the person who is the patient, he or she should own the data because it's my data.
I think that's what
okay. Yeah, I thought. Yeah, I thought there was some. Sorry, my apologies.
It was.
Perfect. Own the data. That's what it is.
Thank you, sir, for the clarification.